Hello and good afternoon. Thank you all so much for joining us today. My name is Alexis Smith and I am the International Partnerships and Programs Coordinator, and I just want to thank you again for joining us for the November Clinical Culture and Diversity Series. And this is a very special event as it is the third annual Dr. Mani Modale Mani International Educational Exchange and Partnerships presentation. We do have continuing education credit available for today. If you would like to receive credit, please make sure you log in to Zoom and you are logged in with your full name. I did include the attachments in the chat, but I will quickly review those here for you as well. And just in case you didn't see earlier, this is International Education Week, and I would like to share a message from our Senior International Officer. Happy IEW 2021, and welcome to this program sponsored by the Office of International Programs at KUMC. According to the Department of State, International Education Week, or IEW, November 15 through 19, 2021, is an opportunity to celebrate the benefits of international education and exchange worldwide. This joint initiative of the U.S. Department of State and the U.S. Department of Education is part of our efforts to promote programs that prepare Americans for a global environment and attract future leaders from abroad to study, learn, and exchange experiences. International Education Week is a week for celebration. A celebration of diverse cultures, languages, people, and the relationships and connections we have forged here and across oceans and continents. This is a time to celebrate our friendships and to celebrate in our collective and individual accomplishments. After navigating new challenges for 2 years due to the complexities of COVID-19, which halted international mobility, we are excited for the resumption of in-person exchange. This week is our opportunity to stop and shine a spotlight on the wonders and wonderfulness of interacting with people from around the world. While we have awaited the resumption of in-person exchange this past year, our international engagement has not been stopped. We continue to communicate and engage virtually with our friends and partners around the world. And this week, we welcome our first international delegation since the pandemic. We are pleased to welcome our friends from Kenya Medical Research Institute, Dr. Eliza Sanjak, Mr. Samuel Kamadi, and Ms. May Maloba, hosted by Dr. Sarah Kessler. We were not discouraged. Rather, we are leveraging opportunities. OIP began our second year-long Foundations of Global Health series, which offers programs geared to promote our community to be leaders and catalysts of change, who defeat health disparities by ensuring health equalities. Over the past year, since our last International Education Week, we at KUMC have stood in solidarity with our international friends, colleagues, and coworkers. Here at KUMC, we know better than anyone how much our international friends contribute to our community and how desperately we would miss any of them if they chose to work, study, or do research elsewhere. Diversity is essential to creativity of thought and expanding our mental horizons and understandings. Simply put, we all need to interact with others who think differently and perceive the world differently, as it makes each of us better, smarter, and a little more empathetic and understanding. As Senator Fulbright stated, we must try to expand the boundaries of human wisdom, empathy, and perception, and there is no way of doing that except through education. The essence of intercultural educations, the acquisition of empathy, the ability to see the world as others see it, and to allow for the possibility that others may see something we have failed to see or may see it more accurately. We know the value of individuals from around the world who come to the US to study and how their presence in America contribute even more profoundly than the $41 billion they contribute yearly to higher education, as reported by NAFSA, the National Association of International Educators. International students, scholars, and employees are part of the heart of our institutions and are woven into the beautiful tapestry of American higher education and American society. To say we are grateful for their presence seems grossly inadequate. We could not imagine our lives here at KUMC without the presence of internationals and international exchange. And now it is my pleasure to introduce a good friend of OIP's, Dr. Anthony Kovac.
So it's my pleasure to be part of this third annual presentation. And first, I'd like to give a little bit of a bio of Dr. Mani M. Mani. Mani is a professor emeritus in the KU Department of Plastic Surgery. Born in India, Dr. Mani graduated from Christian Medical College in Vellore in 1961 and completed general surgery training there in 1964. While training under the renowned Paul Wilson Brand, MD, he crossed paths with Dr. David Robinson. That relationship led to the invitation to visit KU Medical Center in 1969 for plastic surgery training and decades of partnership and innovation. On completing his residency, Dr. Mani returned to India. In 1972, Dr. Robinson visited Dr. Mani and asked him to join the faculty at KU. After moving his family to Kansas in 1974, Dr. Mani was selected the medical director for the Jean and Barbara Burnett Burn Center. The protocols for contemporary burn care he developed at the Burn Center was ultimately adopted as a standard of care by every city, hospital, ambulance, and fire department in the state of Kansas. It then became the standard of care in many parts of the US and abroad, including Malaysia, Australia, Kyrgyzstan, and India. Although Dr. Mani officially retired in 1999, he remains active on campus, including as a regular lecturer and with his involvement in telemedicine initiatives for the Department of Plastic Surgery with residents around the world. Because of his pioneering efforts and global health examples teaching burn care and plastic surgery around the world, the Office of International Programs, Dr. Mani M. Mani International Education Exchange and Partnerships presentation was initiated and named in his honor to be presented during International Week at KUMC. And at that, I return it back to, well, I guess, okay. Also, part of my presentations is to introduce today's speakers, which we have two speakers. The first speaker, Dr. Richard Korentager, I know him as a friend working with him in the operating room and burn unit. Dr. Richard Korentager is the David Zamorowski Endowed Professor of Plastic Surgery and the chair of the Department of Plastic Surgery at the University of Kansas Medical Center. He earned his MD degree from the University of Toronto in Toronto, Canada. Completed his internship at St. Michael's Hospital in Toronto and his plastic surgery training at the University of Toronto program. Dr. Korentager went on to complete 6 months fellowships in breast reconstruction, as well as hand micronerve surgery. He spent 10 years in private practice in Toronto, Waterloo, Iowa, and Kansas City. He's been on the staff at KUMC since the year 2000. He was program director of the Integrated Plastic Surgery Program at KUMC. He served as the medical director for the Burnett Burn Center for more than 10 years. Dr. Korentager has been involved in the ACE program at KUMC since its inception and was an assistant director for 4 years and is currently the director of the ORS Society. He has been involved in providing care at international sites since 1996 and has worked with a number of volunteer plastic surgery societies, including Operation Smile, Interplast, Medical Mission Foundation, and is currently working with Dr. James Butterworth on a long-term partnership in San Lucas, Guatemala. They have established the KU Department of Plastic Surgery International Experience Fund, and he has started the Mani Mani Opportunity Fund. We also have another speaker in a dual faculty role as clinical assistant professor in plastic surgery, and within the KU School of Nursing, Dr. Suzanne Mitchell, PhD, serves as an advanced practice provider and an educator. Dr. Mitchell graduated in 1994 as a family nurse practitioner. Originally from the East Coast, she relocated to the Midwest in the year 2002 and met Dr. Korentager in 2005 while working at Shawnee Mission Medical Center, which is now the Adventist Hospital, in the Wound Care Center. In 2007, she transitioned to the University of Kansas Health System and began her career in the Department of Plastic Surgery, specializing in acute burn injuries and chronic wounds. As KUMC is an academic medical center, in 2008, she pursued her PhD in nursing from KU, and in 2015 graduated with a research focus on telehealth, telemedicine, and burn and wound patients. So I hope you will join me in applauding and listening today to our day speakers.
Well, first, I want to thank you all so much for joining us here. I will pull up our, there we go. There we go. Oh,
Where'd it go? There it goes.
yep. You can all see that.
I'm assuming that's a yes.
Yes, we can.
Okay, great.
You just want to move it to presentation mode. So if you want to hit the little pull down button so we can see the full screen. If you look at the right hand on the bottom side, the bottom, you'll see a little like PowerPoint screen right next to the Zoom.
PowerPoint screen next to the Zoom.
The zoom in feature.
That Zoom?
No,
This?
Yep, that's it. And then if you go to display settings,
so there.
yep, go to display settings at the very top.
Are you sure you don't want to be
display
here with
settings.
us here?
Yeah.
And then,
And then swap. Swap.
Are we good?
Perfect.
okay.
Woo!
Well, thank you for the technical assistance there. All right, first of all, just want to thank all of you for joining us here and putting up with my technological ineptitude to begin things with. So what we'd like to do is we're going to try to save a little bit of time at the end to see if there are any questions. And the topic that we'd like to talk about is improving access to care for underserved areas in Guatemala, cultivating partnerships in education and clinical services. So Suzanne and I are going to sort of tag team this, and she is going to begin.
Well, I had the privilege of accompanying the Department of Plastic Surgery for my first medical mission to San Lucas, Toliman, Guatemala in February of 2020. I'm not an OR nurse, and you really don't want to give me any tasks in the OR. So my purpose was to assist Dr. Toon in caring for patients with burn and wound injuries in the hospital clinic. During our short visit, besides providing direct care, I also had the pleasure of participating in an educational in-service for some of the health promoters in Guatemala, as well as the nursing staff at the hospital. Unfortunately, because of the pandemic, we have not yet returned to Guatemala in person, but we have continued our relationship with Dr. Toon and the residents of San Lucas through a wound telehealth clinic that meets every other Friday afternoon. This past year and a half, I grew to understand how a partnership can flourish, blending education, clinical services with cultural awareness to improve health outcomes and reduce disparities. So with that said, I'd like to share our story, our partnership with Dr. Toon, his staff, and the community of San Lucas, Toliman. San Lucas, Toliman is a town of 17,000 people that sits on the southeastern shore of Lago de Atitlan, described as one of the most beautiful lakes in the world. Spanish, however, is not their first language, and I may be mispronouncing this. Cachico is the Mayan dialect spoken in the San Lucas area. It is located in the central highlands of Guatemala, where the area is primarily an agricultural community growing coffee and avocados. The village sits on the shores of Lake Atitlan and is joined by many other communities surrounding the lake, none of which have a hospital with surgical capabilities, and few even have a clinic. The closest government hospital is in Solola, which is approximately 1.5 to 2 hours away.
So another interesting little thing about Lake Atitlan is that the sort of mountains and hills that you see around it are all volcanic. So it's actually surrounded by dormant volcanoes. And as Suzanne said, it's just an absolutely beautiful area. So one of the things that we've really tried to do is develop relationships there. And the plan that we have is to visit twice a year. So run regular clinics and surgeries twice a year in the region. And what we have done is found this, the Hotel y Restaurant Toliman, which is the place that we've stayed at each time. The picture you see here is a team meeting of our group. The lake or the hotel is very close to the shore, and it's a fascinating hotel. It's an eco hotel, and it provides jobs and food for the community. And they actually continued to do this during the pandemic with some GoFundMe campaigns. One of the amazing things to see when you're sitting having breakfast on the porches that sort of overlook the lake is they have these hummingbird feeders, and the hummingbirds literally just swarm the feeders. It's just incredibly beautiful. At the hotel, Carmen, who you see in the left, Carmen is a Guatemalan native who lives in Kansas City and really has been central to the development of this program. She has got contacts throughout Guatemala and is the one who can make sure that everything happens and runs smoothly. And she also acts as one of our translators. So in the picture on the left, you're seeing Carmen with one of the hotel staff who is the runs the garden and cares for the garden. The garden is actually several acres, and they grow a huge variety of vegetables, fruits, and herbs. And they are all served at the hotel. And then they also grow a lot of additional food that is given to the staff at the hotel to take home, and then also to people in the community who are in need. This is the other side of San Lucas. So I think it's important for us to all understand where the resources that they have and don't have. So the gross national income per capita in Guatemala is just under $4,500 a year. Most of Guatemala's workers do not even receive the minimum wage, and indigenous workers receive even less. And in fact, the indigenous workers make up the majority of the Guatemalan population. Over 60% of the workers in Guatemala earn less than that minimum wage, between $2,500 and $3,000 a year. But to put things in perspective, a family of four, the estimated yearly costs for or monthly cost for a family of four is almost $2,100 a month, and another $100 to $150 a month for rent. So it's clear that they barely even make enough money to cover 1 month, let alone a whole year. The picture you see here is something that we would see as we would be walking to the hospital, these sort of narrow alleyways and lined with homes on either side. And as you can see, the conditions are are very rough in many of them.
So this is a picture of the hospital in St. Lucas where we visited. Dr. Raphael Toon is the medical director of the San Lucas Hospital. And as previously described, the National Hospital is located in Solola, and the National Hospital will charge a minimum fee of 3,000 Qs for treatment, which equates to about $400 US. Also keep in mind that that's approximately 3 months of wages for an entire family. The hospital in San Lucas also charges, but approximately 200 Qs, which is about $25. Dr. Toon explains that this is for the patients to own their responsibility in sharing the expenses. Understand that this is a major sacrifice for the patients. As a farmer, the average daily wage is $7.50. Add to that transportation costs, which could be about $13. So if the 200 Q fee is a barrier for the patient, the San Lucas Hospital, which is funded by the Friends of San Lucas, Friends of San Lucas, will generally waive that fee. The fee is mostly a symbolic and is just meant to give the patients the feeling that they are contributing to their care.
The Friends of San Lucas is a not-for-profit that is run out of Edina, Minnesota. And they have been active in San Lucas for many years. And they've got healthcare providers from around all over the US who provide support, and some from other countries as well. Dr. Butterworth, who is a microsurgeon in our department, has taken a tremendous interest in San Lucas and is now head of the surgical committee for the Friends of San Lucas.
This is actually an image of, I believe, the operating room at the hospital. So the hospital is a 32-bed facility which serves the San Lucas community and the surrounding communities. It has 10 beds that are for children, 10 beds for women, 8 for men. They have 1 isolation room and 3 post-delivery rooms. They have a pharmacy on site, an emergency room, a delivery room, X-ray capabilities, and an eye and a dental clinic. The focus is on providing quality outpatient services and emergency care for urgent health problems. They run through about 50 to 100 patients a day. They're the only facility in the area that's open 7 days a week, 24 hours a day. So again, we've been talking about partnerships and friendships, and there are many others that are part of the team. Carmen, again, another picture of her on the left. Dr. Toon, you can see him on the right. And below Dr. Toon, so they have graduate students that I believe come from Stanford University and spend quite a long time there. Previous to Patrick, who is there on the bottom right, was a graduate student, Allie, who is now in med school. I forget where she was going to school, somewhere in California. But they spend like months and months there, and then sometimes they'll spend a year there, but then go back and forth from there to the US. But they have many roles and functions, but for us, Patrick serves as an interpreter along with Carmen when I'm doing my Friday telehealth visits.
So, it's interesting, during the pandemic, Allie, who was a young woman who'd been living in San Lucas for quite some time, she was just about ready to go back to the States and ended up not being able to leave for close to another year.
Yeah, she was a long time.
Yeah, as a result.
So as we stated in the opening, central to establishing and building our relationship with Dr. Toon and trust with the San Lucas community is acknowledgement and respect for the social, political, and cultural differences. Cultural competence has been defined as the ability of providers and organizations to effectively deliver healthcare services that meet the social, cultural, and linguistic needs of patients. And although there are many strategies to improve the patient-provider interaction, I've listed 4 of the most pragmatic strategies appropriate for us to involve coordinating care using community health workers, for example, the health promoters in Guatemala, incorporating culture-specific attitudes and values into our healthcare decision-making, and utilizing hospitals, clinics that are most accessible for the population. So next, we want to share with you how we've integrated clinical services with education to bridge that health disparity gap. So Dr. Korentager has spoken to the history of the Department of Plastic Surgery's relationship with the Medical Missions Foundation and our relationship with San Lucas Tolomon, and the birth of our relationship with San Lucas, which I believe was in 2018. I was fortunate to have the department ask me in February of 2020 to accompany them to Guatemala and collaborate with Dr. Toon. Again, my role was to treat patients in the outpatient setting that had acute wound injuries. And we've seen a lot of patients that had venous leg ulcers and diabetic foot ulcers and some acute burn injuries. We also had the opportunity to go to an individual's home who had a very large abdominal wound, fistula from a typhoid infection. So since February of 2020, we have not returned to Guatemala. And so because we couldn't go there, Dr. Toon identified with Dr. Butterworth and Dr. Korentager a need for continued wound consultation. And so we thought that we could meet via telehealth. And initially it was every Friday afternoon for about 1.5 hours. And we would go through about 4 to 5 patients. And it was time consuming because of, having to translate. We had to go over the patient's history, their past medical history, and then we spent a lot of time formulating a plan of care, which we are very fortunate that we have an abundance of resources at our fingertips, but there they don't have a lot of wound care products to choose from. But they do have some topical wound products, and they have a good amount of antibiotics. They had X-ray capabilities and labs. So interestingly, during the telehealth visits, I would say almost all of the patients, even if they came in with a venous leg ulcer, all of them had type 2 diabetes. So we really identified, this particular patient had the absolute misfortune of presenting on his first clinic visit with a very horrific diabetic foot ulcer that ultimately resulted in a partial amputation of his foot. So our goal is to educate the community on proper diet and daily foot inspection, and collaborating with Dr. Toon to triage these patients to a higher tertiary care center. Ultimately, the global initiative is limb salvage. This was just a slideshow of an in-service that I gave to the nursing staff when I was there in February of 2020. And we just basically gave an overview of chronic wound care. And then during the telehealth sessions, Dr. Toon wanted us to give another in-service that was specific to care of the diabetic foot. And so Patrick, I didn't know he was going to do this, but he spent a lot of time translating all of the English language into Spanish language for me. And during that session, which took place in October of 2021, we identified more needs on nutrition education. And so currently we are talking back and forth about how to take the Guatemalan diet and make it a healthy Guatemalan diet that parallels the American ADA diet. So that's currently what we're working on now.
One thing I'd like to sort of add to this, this relationship, something that came out that was unexpected was that during COVID, we would have these meetings with Dr. Toon, and he would talk to us about the needs that they had, both for materials as well as for education. And Dr. Castro and the ID team from KU actually presented a couple of educational programs for Dr. Toon and the nursing staff at the San Lucas Hospital, so that they would be able to optimize their management of COVID patients.
So health promoters was a new concept for me. So health promoters, I think it was established in the 1990s, and these are lay persons within the communities that actually serve as a first responder or that first contact of care for individuals. And they really rely on education from experts and guidance. And so I don't know which town we were in. It was a very rural community. And the person standing up to the left of me is Enma. And Enma is from Guatemala. And she kind of basically runs the health promoter program in that region. And so part of one of my goals, which we're going to get to at the end of this program, is understanding more, immersing myself more within what the health promoters do and their level of education. Because I really feel like the in-service that I gave them that afternoon was probably way over their head and not really not very helpful. But the Dr. Toon really, I think, relies heavily on the role of the health promoter in advancing good health and good outcomes for the community. And that's Enma and me. And this is how rural we were in. So there's no road to where we were at. They kind of drop you off on the side of the road, and you just take a walk along this path and get to a structure where people are located. So it's very pretty though.
Beautiful country. So I'm going to take over for a little bit now and start to talk to you about the surgical aspects of what we're trying to accomplish. And one of the big differences of what we're doing now, and in fact, many of the programs, the international programs, have sort of taken a pretty significant turn from planning on just sort of dropping into a country and operating for 1 or 2 weeks and then leaving and just not coming back and not really following up, to programs where we're really trying to develop these long-term plans and long-term relationships. So, initially it's how do you get the word out? And it can be very challenging. You're dealing with urban communities, rural communities, limited internet and limited connectivity, multiple languages, and then a lot of mistrust, because there's mistrust of the government. As we were saying earlier, the majority of Guatemalans are of Mayan descent, not Spanish descent, yet they have been subjugated for hundreds of years, many hundreds of years. So one of the things that we would sort of start with would be talking to the health. They would be speaking to the health promoters. We would put signs up. There would be to talk about what are the kinds of things that we can be dealing with. And so here you're seeing some diagrams of a child with a cleft lip and a cleft palate, another with a burn scar in the neck that's going to be released, and then congenital ear deformities. So I'm going to ask Suzanne to tell you a little bit about what it's like that very first day when you show up for clinic.
Yeah, this is the first day of work. This is at the hospital, a little room with a lot of people in it. And literally, we were in that room for about 12 hours. there was probably about 20 patients per page, and it was pages and pages and pages and pages of patients that were coming to see us to have surgeries. And they literally, they would bring a patient in, and Dr. Butterworth and the chief resident and Dr. Bobsar would look at the problem, decide what needed to be done, if it could be done in one operation, if it was a 2-stage operation, and how many hours. And then all of that was put on an Excel spreadsheet, and then magically the OR schedule for the week came from that. But it had to have been almost 200 patients that we saw that day. It was crazy. It was crazy.
It's a remarkable experience. You know, you look out the door and you see patients just.
Oh, they get there at like 5 in the morning and they just wait.
And they wait,
Mhm.
and they wait,
Yeah.
and they wait. And there are patients that came, you know, if you think about the cost of healthcare, there were patients that came from hundreds of miles away. And you know, people would walk for days just to get there. So you would never think of saying, well, we're done, we're tired. You just keep going until you've seen everybody. So this is what Suzanne was talking about. This is an operating room schedule. And so the surgeons would sort of get together the night before, and we would look at all the different cases that needed to be done. And then you would try to decide what was the safest order in which to do them. Some of the cases are very quick. We would always try to get the youngest patients there. You see in the bed 2, there's a 3-month-old and a 2-month-old. So you would try to do the youngest patients, you know, first, and then you would sort of work your way through the list. You always had to be very flexible because, you know, things would change. The cases were a tremendous sort of variety, and you really needed to be prepared for just about anything. This is our pre-op area. You can see we're out on a porch here, and it's open air, so patients would come in. They would then get registered, and we would they would get prepared for surgery. So we had volunteer staff, and we had translators available. The young man in the center there with the Roots t-shirt is my son, who I pulled rank and was able to bring him along, and he was able to actually really help out with a lot of things. The other picture you see beside, you know, the kids would be in there for, in many cases, hours. So the staff would do whatever was necessary to keep them entertained and not be as worried about not being able to eat. So here you're seeing in the operating room, a little different than the standard KU operating room. We have 2 tables running in the operating room. Just at the bottom of the picture on the left, you can see there's sort of the beginnings of a large table where we just had laid out large numbers of sterile instruments, and you would literally go over, pick up what you needed, and walk back to a sterile table where you were working. This does help to improve efficiency, but it certainly requires everybody to be thinking and have their always be looking where they're moving and not contaminating things. The equipment is all sorts of different ages, and so having biomedical engineering support is essential, and we were very fortunate to have tremendous support from the health system staff to help with that. Constant cleaning and re-sterilizing of equipment. There you see my son again. He got put to work scrubbing instruments and was taught how to problem solve the steam sterilizer that was a lot older than he was. Unique surgical needs. So, you know, you would see things that you've never seen before. Firewood used for heating and cooking. And when families are making less money in a year than they need to cover a month of expenses, they always had to find different ways of making things work. And laborers would frequently, they would climb the hills in the region and they would collect this firewood to sell. It was literally backbreaking work. The gentleman that you see on the right, that was the only way that he could make enough money to support the family. And he had a severe problem with his back and was not able to work as a result. So we took him to the operating room, and I was able to remove that large mass from the central portion of his back that had developed as a result of years of carrying those large stacks of wood. He recovered nicely and was able to get back to work, and we gave him a whole bunch of foam to use to provide a little more padding for his back. But you know, things like that, if we hadn't been able to provide those services, it puts that family in a really rough place. Something that we saw a lot of there is congenital ear deformities, a much larger number of patients than we were expecting. These are staged procedures with creation of a cartilage graft construct. And we wouldn't have been able to even begin these if we had not planned that we were going to be doing this twice a year. COVID obviously has disrupted some second and some cases third stage procedures, but telehealth has allowed us to continue to follow up with the patients and plan for future surgeries. So we know that there is a significant backlog of patients waiting to be treated. Burn injuries, they're a particular interest of mine and Dr. Mani's. Thermal burns, a major public health problem in developing nations, cooking, heating over open fires. The burns often become infected with delayed healing, and these can result in very severe burn scar contractures. We'll treat these with surgical releases, and then through working with Dr. Toon and knowing that we're going to be back, we've been able to also teach them splinting techniques, getting them the supplies that they need so that we can have successful treatments of these burn scar contractures. This is a picture of a young man that his family brought him in from Quetzaltenango, or Chela, which is the second largest city in Guatemala. It's about 3 hours. If the weather is good and the roads are open, it's about a 3-hour drive from San Lucas. And they brought him after hearing about our program for treatment. So he was on my schedule to treat the next time I was there, but have not been back since. So presumably the next time that I go, this young man will be on our operating schedule. Here's a picture of a young man that I treated with a cleft lip and nose deformity. So societal taboos result in very limited opportunities for kids who have clefts. So repairing the cleft lip and or the cleft palate can be life-changing for them. This young man had a very severe nasal deformity with collapse and inability to breathe through his nose. And so we were able to do a one-stage reconstruction of his nose and get him to a point where he was able to breathe through his nose and was comfortable. So that was a one-stage operation. Now, after we finished in the OR, we're always thinking about the post-operative care and education. These pictures are taken in the hospital section of the San Lucas Hospital, and all the rooms are ward rooms. There are no single rooms. We have their nursing staff. Rachel, who is on the right in the center picture with the sweatpants on, she is a remarkable nurse who has been incredibly dedicated to international work for a very long time, provides services both in the operating room as well as education and translation services. There are times when we would need to have one translator to translate from Mayan to Spanish and another one from Spanish, or from Mayan to, from Spanish to English. So all sorts of things that, you've got to think about. And as you can see in the picture on the right, Dr. Butterworth is at the bedside along with one of our previous chief residents and Dr. Toon and the nursing staff from the hospital, and we're all discussing, what the post-op course is going to look for. You need to really think about everything and anticipate any dressing, medication needs that the patients may have, and make sure that they have all the supplies they need prior to discharge, because they are not able to go to their local CVS or Walgreens to pick things up. I wanted to point out, something that's done through KUMC that is on the other end of Lake Atitlan from San Lucas, is in San Pedro, which is a slightly bigger community. In San Pedro, they have a medical student site, and this was something that Dr. Kennedy was heavily involved in and was running. Obviously, it's closed down since COVID, not sure when that's going to be started. You see the little taxis, those are transportation that we'd often use in these areas. And then the picture on the right is just to show that, yeah, we do have a good time too there. After we finish packing up all of our supplies and we're getting ready to leave the next day, we would try to save some time to go and just enjoy the region. And this is zip lining over Lake Atitlan, and you are up as high as several hundred feet over the lake on these zip lines. Now, I want to spend a minute talking to you about something else in terms of something that I got very excited about, that I think has got tremendous opportunities for us to get involved with in the future. The Foundation de los Niños is in Quetzaltenango. Quetzaltenango is also known as Chela. That's the second largest city I was telling you about earlier. Ricardo, who you can see in the picture there, is the director of this orphanage. And it's an orphanage that only takes in very young children. And these are children that are either found on the street or taken away from families that are in horrible situations. And they move to this orphanage, which is on probably 30 or 40 acres or more on the outskirts of Quetzaltenango. And they live in these cottage homes with their own age group and have an adult living in the home as sort of a surrogate parent. They get separated by gender when they get into their teenage years, but prior to that, it's just, big family. They've got small kitchens within the homes, but they all eat together. Now, one of the things that's fascinating about this place is they do all of the education for these children up through high school, and then for high school, they move them off-site into Guatemala or into Quetzaltenango. They educate them for trades on site. So you can see there the setup that they have to teach them about auto mechanics. They teach them sewing skills. So they will work in many of the factories in the area, and they can actually go on to get professional degrees that are recognized by the Guatemalan government. This young man that you see there was brought to the orphanage when he was a baby, and he continues to work there, and he repairs all of the cars and trucks that are there. The computer lab that you see all just a bunch of different computers, and the way they teach computers, since a lot of the computers don't work, is they teach computers on a whiteboard. So they do as much as they can with what they have. Small things can make a big difference. When I visited there the first time, I saw they had a library, but you can see the library on the right, but there were very few books on the shelves. So when I went back, came back to KC, I challenged my son to start a book drive, and they were able to collect 250 pounds of books that from Indian Hills Middle School that were shipped to the library and then fill all those shelves now. And they allowed the librarian there to start an English language program, which will be tremendously beneficial for the kids. We're getting close to the end here. So, you know, it takes a village. The KU team includes surgical, medical, anesthesia specialists, advanced practice nurses, nursing staff, LPNs, MAs, administrators, translators, biomedical engineering, and then the St. Lucas Hospital team, which includes Dr. Toon, nursing and administrative. Dr. Toon loves everything Kansas, and I was able to get him an autographed KU basketball, which is now on display in the hospital. And there's a picture you see of all of us in front of the hospital, along with all the hospital staff towards the end of our trip.
In closing, I guess we all have to have goals, and I just feel a strong passion to go back to Guatemala to really immerse myself more into understanding their culture and the health promoters and their social determinants of health, looking at their housing structures. You know, some of them have dirt floors, looking at the kinds of work that the patients are doing. And some of them are doing work to support, or we're doing work to support local businesses.
Yeah, this I just sort of I'm trying to confuse her. So what you see in the top right, those are scrub cabins that that we would bring a couple back, and everybody would ask me about them. And Carmen helped connect us with women in San Lucas who during the pandemic had no way of supporting themselves. And so we contracted with them to make scrub caps. And so they ship scrub caps. These are all textiles from the region. And we've been giving those out and providing to people. The picture at the bottom there is really just to remind me, when I was in Quetzaltenango, each time I go, I like to go there and I visit there are several universities. What you're seeing there is actually a classroom from one of the private universities. And we are working to develop relationships with the private and the public universities so that they can send some of their students to San Lucas to train with us while we're there, so that we can, you know, working with Suzanne, the local health promoters and the students, we can train them in a variety of different techniques. We have also had one of the a student from the area has actually come to KU and spend some time with our plastic surgery service as well. This was several years ago, right at the very beginning of the program. So let me, I'm just going to end by thanking you all for your attention and see if there are any questions.
So there was a question in the chat earlier. In the case of foot amputations and other occupationally detrimental injuries, are there any additional programs to reintegrate the patients into their original roles and jobs, especially since you mentioned that this area relies heavily on farming?
Yes. So we actually have had in our telehealth sessions, 2 patients that have had to have amputations. Unfortunately, things are done differently there. And again, the resources aren't there. So there's no prosthesis. Basically, he ended up having an above the knee transfer amputation and would have to basically got around on crutches. The picture that you saw was a recent amputation that was like a transmetatarsal. So just that side of the foot was amputated, and we're supposed to be seeing that patient again in the next couple of weeks. So it is a good question, but I think the answer is going to be that they're going to have to, whatever they can do, they can do. I mean, there's not a lot of.
Well, it's actually a great question.
Yeah.
And, I think the future generation. So one of the things that when my son came back from there, he's very interested in engineering and 3D printing. And he wants to develop sort of things that will allow us to do some 3D printing of, partial leg prostheses. There's been some things done with hand prostheses, 3D printing, very inexpensive, that again, may be life-changing. So who knows, what the future is going to bring. And I was just looking, Kimberly was asking about specialty training for Guatemalan doctors in the area of plastic surgery and long-term vision implants. She's asking this because she and I have spent a lot of time in Quetzaltenango, talking to the universities. We were starting to get some traction, and then COVID hit. Our goal will certainly be to get those conversations going again and seeing what we can do in sort of a two-way training program. I'm probably going to lean on Dr. Kovac, since I know he's has been developing programs like that in Peru and in Africa, and we are going to steal as many of his good ideas as we can. Tell us what you have learned from the local physicians and local workers, community health workers, everything.
Yeah, I mean, I was only in Guatemala once, and so I only had interaction with the health promoters that one time. And honestly, I didn't have direct conversations with them. I really feel like my inability to speak their language is, a disservice to them. So I am looking forward to going back and spending more time with the health promoters and having them tell me what I can do to help them serve their communities better. So that's high on the list.
I'd say the other thing, and this is something I learned from when we were doing telehealth with India, the amount of the novel treatments and things that they're doing that we can take and try as well. So there's just all sorts of opportunities, to learn from them just as much as they learn from us. Well, it looks like we've hit 1 o'clock. Alexa, leaving it up to you now.
Sure. Dr. Kovac, was there anything else you wanted to add?
Well, one thing I guess I would like to applaud our Dr. Korentager and the of having a multidisciplinary team with not only doctors but nurses coming over is something I think it's good for. I think us as KU to show our presence, but also for the people in the foreign country in Guatemala to see your involvement and commitment. And I applaud your efforts for the idea of sustainability and teaching, because I think this is, in my mind, the spirit of what I've gathered and learned from Dr. Mani, of how we, to go forward. And I guess one question I have is that with regard to, let's say, the training, like you've gone to a community, have you thought too of making connections with the medical education system in Guatemala or the universities, you know, with that regard to training the specialists there?
So yeah, we've talked to the universities, and again, I think we were sort of starting to get a little bit of traction when we were, you know, just when COVID hit. There is very limited training opportunities, and you know, unfortunately, what happens with a lot of the specialists, they end up in the big cities and aren't interested in the smaller communities. One sort of novel thing that we were also starting to get going. Kevin, who is our biomedical engineer, was looking at seeing if we could develop a training program sort of at a technical college level for biomedical engineering, because, you know, again, the equipment that they have often needs to be helped. It needs, you know, it needs to be helped to just sort of keep it going. They can't just buy new. So that was another area that we've looked at as well.
Dr. Korentager, can I join in for just a second? This is Kimberly.
Of course.
Dr. Kovac, one of the challenges we've had in Guatemala is not having the personal connections like you have and enjoy in Peru and Ghana with like Dr. Alfred Adu and some of the people that can really help move those relationships along with universities. So Dr. Korentager, Dr. Butterworth, and I spent a lot of time meeting with universities in Guatemala, and we just didn't find that hook, you know. So we're working on it. We hope that will definitely pan out. It's definitely a long-term goal that Dr. Korentager has. I would like to say that Dr. Korentager, Dr. Butterworth, and their team has done a tremendous job of expanding the breadth of what this is. This, you know, international educational experience and surgical training trip to Guatemala has really evolved from your typical medical mission to collaboration and relationship building. And there's just so much potential for that exchange to continue to grow, which is one of the reasons why we are just so proud of Dr. Korentager and his team and wanted to highlight them. And it's such a pleasure to meet you too. Yeah. And to, just say this is a great example of something that has evolved and that as a university, we are, very proud of and want to promote and see what else we can build, because there is a lot of potential.
Yeah, it's the multidisciplinary, which is, I think, just so important. The work that Suzanne's doing with the health promoters is really unique, and it's also got some great opportunities for research and for making just huge inroads. We surgeons will we sort of end up treating the end results, and the things that Suzanne is doing is going to potentially prevent us from having to treat some of those end results, which is what we would all love to see.
We want them to be a little bit more self-reliant. I think that's the purpose, right?
Yep.
Give them knowledge and
give them knowledge, right? Teach them how to fish. Isn't
right.
That's the value. Yeah, no, we're very excited. Thank you so much for giving us this opportunity.
I'm proud of my department.
And we're proud of her. Thanks, everyone.